Let's go.
Yeah. Welcome everybody.
Hi, everyone.
All right, so we have good number of folks coming on. Good to see everyone. So I'm Kelsey. I'm the program manager here with MathNet, our technical assistance center in Massachusetts. Please feel free. Oh, is there an echo? Are folks hearing that? No. Yeah, let me know if it is still a problem. We can try to problem solve that. Um, But please feel free to introduce yourselves in the chat, and I will give a brief introduction to our presenter today, Dr. Cheryl Fu, and then we can get started. Dr. Cheryl Fu is a clinical psychologist and researcher who's focused on making evidence-based treatments for individuals with serious mental illness more accessible and used in community care settings. So she's the Associate Director of the Massachusetts General Hospital Center of Excellence for Psychosocial and Systemic Research, the Director of Family Services of the MGH First Episode and Early Psychosis Program, and an instructor in psychology at Harvard Medical School. More relevant to today, Cheryl has been working both with our team and separately on a project around really this really important question that's come up across a lot of our programs, which is how do we get families to really engage in the service and what really are the benefits of having families involved in early psychosis care. So she's been working on this for a while, really excited to get some of the results of that shared today, and also to get folks' feedback and kind of comments on that, because a lot of this really was from the data in these Massachusetts teams. So really excited to have you, Cheryl. Thank you for joining us today.
Oh, it's my absolute pleasure. Thank you so much for inviting me. And I'm seeing actually we have so many colleagues from all across the country. So I'm so excited to really learn from you all as well. In both my clinical and research work, as Kelsey mentioned, and I'll try to multitask as I toggle my share screen at this moment. In both my clinical and research work, I've been really scratching my head over how to keep people with serious mental illness and people with psychosis engaged in treatment to give them the best chance at recovery. And I think, many of you all might be facing the same issues and maybe have even better strategies around that. Um, so last year, in the summer, I met with almost all of our first episode teams in Massachusetts, 9 of them in total, to really learn from them what were some of the challenges they were facing with patient retention and family engagement, but also what were some of the unique strategies that they were using. I'm really excited to put together these findings from the data that we collected, um, to share a little bit around what are the program level factors, characteristics, as well as engagement strategies that influence patient retention and family engagement from our first episode teams. This work is really a collaborative effort, as Kelsey mentioned, with MapNet, our early psychosis network here in Massachusetts, the LEAP Center, which is an Alacrity Center funded by the National Institute of Mental Health, and our Research Center of Excellence for Psychosocial and Systemic Research funded by our Massachusetts Department of Mental Health. This is the outline of my talk today, but my key goal, and I want to leave the most time to really open up a discussion around how can we translate these findings into practical applications, and hope, that teams and clinicians over here can really take some ideas away and also provide some more ideas for how to improve the design and the implementation of our first episode services. So let's start first with why this matters. I think, all of us here have probably drunk the Kool-Aid of the promise of early intervention services for first episode psychosis. we have a gold standard treatment model of coordinated specialty care. And we know that when all of the evidence-based components of CSC comes together and are delivered effectively, it can really alter the course of a very debilitating illness. But the big challenge here is treatment disengagement. And when people disengage, that completely undermines the effectiveness of early intervention. That prolongs the duration of untreated psychosis, increases the chances of relapse, and both those things, we know contribute to longer term impairment, reducing their chances in recovery. So the data tells us that 12 to 53% of patients in the United States drop out before the recommended 2 to 3 years of early intervention services. And these are dropouts not because they meet recovery and they're ready to transition out of specialized care, and not because they don't meet the eligibility criteria of first episode services anymore because they age out or because they move out of the country or the state. These are people who are lost to contact or refuse treatment when they can still benefit from treatment. The most concerning is that the majority of these disengagements happen within the first year of treatment. About half of the people who disengage within the first 9 to 12 months. Coincidentally, the first 6 to 12 months of treatment also happens to be when the treatment gains are the biggest. And we know this from the RACE ETP trial of the Navigate Coordinated Specialty Care nationwide. So this first to 6 months to a year becomes this critical window of time where we really need to support people to engage in treatment. And so far, we know about the individual risk factors that predict disengagement. Meta-analysis have consistently shown that it's persistent substance use, medication non-adherence, and limited insight, and this kind of goes hand in hand, and lack of family support and social support that predict disengagement from early intervention services. Family engagement also presents another significant challenge. And when we talk about family engagement, there are a variety of ways that studies operationalize it, and it's typically one of these three things. Participation in evidence-based family intervention for psychosis. So what we consider evidence-based family intervention for psychosis is not just a family process and support group, but tried and tested interventions like family psychoeducation for psychosis, or McFarland's model of problem solving in a multifamily group setting, or behavioral family therapy, or integrated dual diagnosis treatments with families. We also consider family involvement in treatment decisions and treatment planning, and family contact with the treatment team. In Massachusetts, in the Fidelity scale that I'll talk about a little bit later, we assess the degree of family engagement across all of these three components. One of the key goals or common elements, as you might say, about family intervention for psychosis is supporting patients' treatment adherence and understanding or helping families understand what they can do to help prevent a relapse. The data supports this as well. So in a meta-analysis of randomized controlled trials, those receiving family intervention for psychosis had 2 times lower odds of being hospitalized or having a symptom relapse than those without family intervention for psychosis. Not shown in this graph here, but this meta-analysis by Claxton and colleagues also showed that family interventions for psychosis improved symptoms and functioning at the end of treatment. And not just about prevention of relapse, but families can also help support treatment engagement and treatment adherence. So this is really interesting data from our colleagues in Minnesota, and I think there's some clinicians from Minnesota here as well. So Minnesota also does navigate in their coordinated specialty care services. And for patients engaged in CSC treatment, patients whose families were participating in family psychoeducation, as shown by the blue bar, also had significantly more number of individual resiliency training, so individual therapy visits, psychofarm visits, and even supported education and employment or SEE visits in that first critical 6-month period. Yet there's this engagement gap. So although actually a majority of first episode patients actually express a preference for some level of family involvement, only a quarter to half of the families participate in treatment. And the level of engagement is low too. So in the RAISE ETP study, only less than 30% of the families attended more than 5 family sessions. So we know that certain factors like younger patient age, being white, and living with families predict better family engagement. But these actually aren't factors that we can readily modify as providers. So this brings us to our the critical research gaps that our study tries to address. We know surprisingly little about what teams can do to influence engagement. We know that staying in treatment helps with reducing the duration of untreated psychosis, and that is associated with better outcomes. And now we have more recently this growing body of evidence that higher fidelity to the coordinated specialty care model, higher quality services across all components of care, it's also associated with better outcomes. So this recent paper in Psych Services by Dr. Abraham Rosenblatt and colleagues showed that across 36 first episode programs nationwide, higher fidelity actually predicted lower symptoms and better social functioning outcomes by 18 months. And in Massachusetts, this is a paper led by Dr. Nicole Dettori and MatNet that is under review currently. We also found that higher fidelity programs had significantly fewer emergency department visits within the first 6 months of treatment. So we were wondering, could fidelity or higher quality services help with retaining patients in treatment that therefore, support better outcomes? So we wanted to explore this association between fidelity and patient retention and family engagement. And second, we also wanted to understand what engagement strategies that teams were using that were very specific and unique to a CSC team-based treatment for the population that we serve. So to address these gaps, we conducted this mixed method study with 9 out of 10 of our first episode psychosis programs. And we had 2 primary aims. The first was to first get a sense of what were the rates of family retention and family engagement across our programs. So teams reported their census to our Massachusetts, to MatNet every year, starting from October to September. So we were able to track from there the number of patients who discontinued services over the whole program duration. And then additionally, we asked team leaders to look through their program census to give us the number of families with at least one evidence-based family intervention visit across the whole program duration again. So we divided these numbers out of their total active patient to get a retention and engagement rate. And then we also, as for predictors, we also asked our team leaders to fill out a really comprehensive survey on, the different program characteristics and the services that they provided, whether they provided it by telehealth, in person in the clinic, or with home visits and in the community. What was the provider's time effort on these services? How were programs funded? Were they trained? Did they have ongoing supervision, et cetera? And then we also used fidelity ratings on the Massachusetts Psychosis Fidelity Scale, or MAPS for short, which is an adaptation of the Addington first episode Psychosis Fidelity Scale that is used nationwide and also internationally. So an example of that adaptation, as I kind of talked about just now, was with the family therapy criteria. In the Addington scale, it is limited to just participation in evidence-based family interventions. But in the MAPS scale, we broaden it to include family involvement in treatment by proxy, whether an ROI for families were signed, as well as whether there was consistent family contact with the treatment team. So it really captures this degree of family engagement as we broadly defined it. We did logistic regressions with a continuous sum score, as well as t-test univariately. And then in parallel, we also included a qualitative component because we suspected that teams were doing things that were likely not captured by any of these measures, right? So we wanted to get a sense of, what were they doing that they thought were effective in helping patients and families stay engaged in treatment. So we had group interviews with all the 9 teams. 43 providers across different CSE roles participated in these interviews. And we identified the strategies that they were using thematically. And then we compared how many times these strategies were endorsed by high engagement teams versus low engagement teams. So we could start kind of exploring what were some strategies that were associated with higher engagement. So what were the results? Overall, in 2022 to 2023, the mean retention rate out of the 9 programs was pretty high at 86%. So the teams above this blue horizontal line here are what we considered high patient retention teams. And then there were 3 teams that were lower or moderate patient retention. Family engagement averaged at 40%, but was much more variable. As you can see from this graph here, there's a lot more spread. So, ranging from 10% to 100%. The blue vertical line here splits the 9 teams into high family engagement on the right, and then lower family engagement on the left. And there is just one team on the bottom right, Team I over here in the bottom quadrant, that is somewhat of an outlier, where there was, moderately high family engagement, but really low patient retention. And this is because, likely because this program actually serves a much younger population. And there's this requirement, of course, for families to be involved if the patient is under 18, which I think also speaks to, as I'll discuss later, the importance of still some individual client level factors. The 7 out of the 9 programs here implemented the Navigate CSE model, and 4 could regularly conduct home or community visits. So what program characteristics predicted better patient retention? So 3 factors stood out of all the program characteristics and fidelity criteria on the quantitative analysis. First, teams that had higher fidelity on evidence-based individual therapy and family engagement were likely to have higher patient retention as well. And secondly, greater comprehensiveness of clinical and psychosocial needs assessment at intake was associated with higher patient retention. And out of all the criterion, it was particularly whether teams offered feedback to patients and families that was driving this association. And what we made of it was that, these intakes and assessments, it's typically the first touch point for the families and patients to build rapport with the clinician, for the clinician or the team even to orient patients to what CSC services are and what they can provide, and aligning the services with the treatment goals. And perhaps it's this kind of mechanism that is supporting patient retention. And thirdly, this was really interesting. Provider visits during hospitalizations that was practiced by 5 of the teams was also associated with higher patient retention. And I think this really speaks to the importance of maintaining therapeutic continuity during care transitions periods, where in fact people are at the highest risk for disengagement. So our qualitative analysis for patient retention also revealed specific strategies that distinguished high patient retention programs that were not captured by the quantitative um, uh, um, factors. So compared to low retention teams, high retention teams were more likely to provide comprehensive case management related support that could address treatment barriers. So, like one of the teams said, we do anything to get them to our appointments, whether that is, giving them with Charlie cards for public transportation or with PT1s. 83% of the high retention teams did this compared to just 33% of the low retention teams. And when we looked at the qualitative the data, what teams were saying, there was a little bit of a nuance here where there were different models of case management. There were teams that either had an additional case manager or resource specialist on the team, and or had grant funding rather than kind of free fee for service models for the clinicians on the teams, therapists on the teams already, to extend their roles to do case management related and advocacy supports. So for example, like the second quote over here, the clinicians on this team was saying that they can advocate for clients at IEP meetings. They can go for school placement visits, etc. High retention programs were also much more likely to implement periodic treatment reviews. So the 4 teams that were doing treatment reviews, and these were with both patients and families, they were doing it, either an annual treatment review throughout the 2 to 3 years of the program duration, or they were doing these quick 20 to 30-minute monthly check-ins as a team, during the early phase of treatment. Like this quote illustrates, these check-ins, these treatment reviews that brought the team together with the patient and family became an opportunity to not just reinforce treatment progress, but also, align services with their current or changing treatment goals, and then also bring up services and CSC components that they were not utilizing that patients can potentially benefit from. So turning to family engagement, we found a slightly different pattern of predictors on the quantitative side. Team leaders rated just on a single item, how much they prioritized family services in their program from a scale of 1 to 5. And we found that teams that had higher leadership prioritization of family services had significantly higher family engagement rates as well compared to teams that had lower leadership prioritization. interestingly, higher fidelity to supported education and employment services, and particularly teams that provided benefits counseling around SSDI, SSI services, DMH, Department of Mental Health Services, learning accommodations, also had significantly greater family engagement rates. I think this can speak to two possible things. Families are naturally invested and, are helping their kids advocate for disability services, SSDI, and also, learning accommodations or disclosure about disability at work. So that's the way that maybe they're involved in treatment in that way. I think it also suggests that offering practical supports for families also creates some natural opportunities for family involvement as well. We found marginally significant effects for better outreach and engagement practices. So whether, teams were proactive in their patient contact, whether teams also offered flexibility with their office hours, which I think, helps many families who are working attend visits. And also, teams that we're able to provide family intervention visits or family partners or family peer support services in the community or with visits to their home also had slightly higher family engagement. And I think together these findings point to the importance of prioritizing family services within the full CSC model, and also the importance of accessibility and practical support for families. The qualitative findings for family engagement strategies also converged with this. High family engagement teams were more likely to provide case management and practical supports to families. And as one of the teams said over here, the family is going to gravitate to the person who's going to meet their immediate needs, whether that's housing, food pantries, financial support, or getting their child financial support. And the team's going to help with that. What's really interesting, as this team member said, it is through the fulfillment of this practical need that also becomes an opportunity to roll in the psychoeducation piece. And if you recall, this same strategy around supporting health-related social needs also came up was also important for patient retention. Beyond that, what was striking was that all of the high family engagement teams proactively recommended family services upon enrollment, compared to just 40% of the low family engagement teams, meaning to say that family services was either a treatment expectation as part of their first episode program, or there was a strong clinical recommendation for it that was given right from the outset. In contrast, the lower family engagement teams had a slightly different approach, and this coincided with the fact that these teams also had staffing constraints around family services. So these three teams had provided family interventions only if it was clinically indicated, meaning maybe the family was in crisis, maybe there was a family conflict, maybe family was interfering with treatment in some ways, maybe there was, a dilemma with a treatment decision between the family and the patient. These kind of more difficult scenarios triggered a referral for family interventions rather than having family intervention right from the outset. And in addition, I think relatedly, these high engaged family engagement teams also framed family services as educational. As one of the teams explained in the quote, the second quote below, The key is to approach families from the perspective of providing support and education, and the frame rather than fixing the family. And I think when, teams approach with providing referrals to more high conflict or high conflict families or families in crisis, the message that is sending is that, the family has a problem to fix. Rather, the frame cannot be about blaming or pathologizing the family. The frame has to be about how to support this family, how to educate the family with and empower the family with the skills and knowledge that they need to support their loved ones in this recovery journey. And you can imagine this reframing reduces stigma and increases the receptiveness for families to be engaged in treatment. So putting all of this together, we see that patient retention, might be primarily driven by psychotherapeutic factors, high quality or comprehensive intake, high fidelity individual and family therapy, and hospitalization visits that facilitate this care transition. And also, strengthens the therapeutic alliance and goal alignment. The qualitative piece then gave a little bit more insight to the fact that, treatment goals and preferences need to be consistently revisited throughout the course of care. And perhaps, periodic treatment reviews can be a way to realign the team with the patient's goals and really meet the patient where they're at. For family engagement, I think accessibility, whether it's in community or at home visits, and practical supports that involve the family seem to emerge as more important. Also, the fact that, case management and related supports came up as high yield strategies for both patient retention and family engagement in the qualitative analysis, I think also speaks to the importance of paying attention to and, having teams coordinate around how to help patients and families overcome social determinants of health related barriers. And finally, for family engagement, I think the positioning and the timing of introducing family services matter tremendously and can go a long way in normalizing family involvement in first episode treatment from day one. So maybe I'll just pause here for a little bit to take any questions about the study findings. And then we can dive into, what are some of the practical implications and applications of these findings. Any questions so far around the findings or the study? Or we can also open it up at the end.
Yeah, Susan.
Okay, I have a question. When you talk about the periodic treatment review, is that treatment review within the team only, or is it the team with the client and the family?
Great. Thank you for asking this question. This is team review with patient and family. So teams that didn't, there were teams that, yeah, they had frequent rounds, they had frequent team meetings, but but that was not associated with better patient retention. It was treatment reviews with the patient and family that was associated with patient retention. And I think, it really required that kind of like feedback process from the patient to the team, as well as the, reinforcing kind of treatment progress with the patients that I think really supported patient retention.
And I have more to say later. I'm a certified parent peer in our program, and so I'm like, yes.
Yes. Okay, fantastic. I'll love to hear your thoughts. I'll make sure I'll leave a lot of time for discussion. Monica, I see your hand up.
Thanks very much for this. I'm really sorry I arrived a little bit late and missed the preamble. So, but when you were talking about as a parent, by the way, of someone who is diagnosed with schizophrenia, the section where you talked about working with families without pathologizing and rather talking about, I can't remember exactly what was in the bubble, but how to, I think you said fix the problem, whereas I would say maintain or build relationships with your loved one. What do you are you documenting what's sort of included in that? Because it occurs to me that as somebody who started on this journey in 2001, one of the messages we get a lot of the times is if we could just make our kid do what the doctor says, things would get better. And in my experience, that doesn't improve the parent-child relationship. So I'm wondering sort of what that looks like, and whether it's really more about, I would argue the way to go is relationship building, and that the parent is taking more of a coaching role, somebody who can help evaluate the information that's coming in and help with the decision making, but not be deciding and enforcing or anything like that. So I was wondering if that's part of the education for families that you were describing or not.
Absolutely. And I think, that is a really important and part of the kind of psychoeducation, at least with the Navigate model for families, is to really highlight like what role can families play in the recovery in the recovery of their loved ones. And I think what you highlighted is one very important role. I think whether it's supporting but not making decisions on your loved one's behalf on what is in their best interest, right? So I think exactly this frame of like, okay, we are going to support you in we are going to support you as a family member to learn all that you need to know about psychosis, and how to communicate with your child and how to best support your child in the decisions that they need to make in their recovery. Yes. Leslie?
Hi, I'm a family peer partner in the Navigate program in Grand Rapids, Michigan. And I think your findings really do align very closely with what we see. And particularly in my role, if I'm introduced to the family early on in their process, in shortly after intake or during intake, then I see families much more apt to engage and be engaged in the family peer support. We also do the family education models with an FE who goes through those with them. One of the things that I see, and there are natural barriers, right, to engagement, especially with single parents working 2 jobs and those sort of things that just are reality that we can't always get around those barriers. But there is another barrier, and that I think, and not necessarily reflected, is that sometimes, when our clients are coming through and they're going through intake, they will say they do not want their family involved. And they're not minors, so they don't have to have their family involved. And so one of the things that, and I would say that right now it's not consistent, but one of the things that we are trying to implement is to come back around to them after several months and say, now that you're familiar with the program and you're experiencing, the benefits of it, what do you think about having your family involved now? Because one of the things that we do is like, we'll support through other things like flexible hours or providing transportation. And oftentimes I will provide that transportation, and just as I'm providing transportation, we'll have a conversation. And someone will say to me, so what do you do for Navigate? And when I tell them and I explain that I'm like the peer for them, but for their family, sometimes they'll even say, oh, I didn't consent for my family to be involved, but I see now that would be really helpful. So initially, sometimes folks are getting hit with so much information, they don't really know what that support can mean for them and how it can also benefit them to have their family receiving it. And so so just a suggestion, and to maybe revisit that with the participants and see if they would be open now to their family being involved where they may not have been before. But also, if you have any feedback or suggestions in that situation, I would really appreciate it.
I'm so glad you brought that up. I am going to go through a few suggestions and would love to later in the next couple of slides. I think of how to discuss consent or the level of family involvement in treatment, but I think you're raising some really important things that is also captured with this periodic treatment review, right, of revisiting decisions with the patient, that patients can change their minds, especially after they've experienced the benefits of treatment after a while. And it is really important to revisit treatment decisions and also revisit, decisions around family involvement consistently. Thank you for bringing that out, Leslie. And I have a feeling Erin might be able to speak to that too.
Yeah. Well, I wasn't going to speak to that, but I'm happy to.
Okay.
Like in terms of the team meetings, you mean?
Yes.
Yeah, exactly. I work in a first episode program in Massachusetts. So, disclosure was interviewed by Cheryl for this study. And our program does this periodic treatment review like every month. And we often are using it as an opportunity to talk about what services and supports the family's not using. And to like bring it up. So it is kind of integrated into those kind of monthly meetings. And I would love to sort of hear others' experience with doing that, just because it can mean like quite a few meetings, right? It sort of doubles in some cases the amount of like sessions you might be doing in a week. And I actually had a question for you, and just about the study, Cheryl. I was curious if you found any, and maybe you didn't assess for this, but in terms of how telehealth impacted engagement at all, because I would love to hear others' perspective on this idea of in community family outreach too versus something like telehealth, right? Because in our experience, we have a lot of family members that aren't able to come to the center as much, particularly if we're meeting with parents that are divorced or siblings or people that live in different places. So I'm curious if there was any what that looked like in terms of impacting engagement.
Great question. And, that was something we also hypothesized would be related to better retention and engagement rates, but we didn't see an effect there statistically speaking. I think just because all of our first episode programs had some form of telehealth and hybrid, but it was really like the teams that were able to go to do outreach and have visits in the community that was marginally significant for family engagement. Yeah. But I think definitely, telehealth and the ability to do telehealth right now definitely broadens the reach and the engagement of families and patients, and also allows us to enroll patients who are beyond kind of a smaller catchment area. Yeah. Great. Great question so far. And so excited to kind of open this up for more discussion and cross learning. So thinking about what this might mean for our practice, I think the findings firstly reinforces the value of all CSC components when delivered with high fidelity to the evidence-based models. So for example, I think what was interesting for us to see was that, supported employment and education could, when done well with this benefits counseling piece, which is the fidelity to the original IPS model, actually has knockoff effects on family engagement because families are invested in whether the child gets employed, goes to school, gets the right benefits they qualify for. And I think this really also underscores the importance of ongoing training and supervision for evidence-based psychosocial treatments for psychosis, which is one thing that our state does very well with MapNet and the Technical Assistance Center to navigate trainings and consultation calls, as well as these, community calls for ongoing education. Second, I think the findings also suggest, and I'll love to get people's thoughts around how to really build capability around incorporating elements of assertive community treatment or ACT that we know work very well with a very difficult to engage population. That we know that outreach is important and goes a long way towards engagement and getting people the care that they need, where they're at. So perhaps thinking about incorporating a social determinants of health assessment at intake. And this is something that we are starting to do with our clinical high risk program at MGH as part of the clinical assessment battery that we do at our intake. And there are many really brief social needs screening tool by the American Association for Family Practices, I think, and also out of the Medicaid system that asks about, okay, whether insurance might be an issue, whether transportation might be an issue, whether food security might be an issue, would digital accessibility be an issue for telehealth, for example? And if anything that gets flagged in this way, the team and clinicians can really intervene early and preemptively, right? For example, providing patients with transportation support or utilizing some of the services that many states have to get people free or discounted rates of Wi-Fi or cell phone services, or getting them on, in Massachusetts, Mass Health as a secondary insurance in case their parents' jobs are insecure or unstable. So really working preemptively around social determinants of health that can become treatment barriers. And as we found that case management supports are also highly valued by teams. I think it's great that either teams are grant funded to be able to extend the clinician's role to provide some case management like supports and services. And right now in Massachusetts, we have funding from the NIH grant to the LEAD Center to add on this component of care in our statewide study. But I think the challenge really would be how to sustain funding for this important and valuable component of care, case management. And also, I think, investigating or testing perhaps, is it better with an additional person on the team, a resource specialist or a case manager on the team? Or should we think about expanding a therapist's role to also provide case management support? Or should we, preemptively get them DMH services so that they're attached to an ACCS or like a case manager externally during their treatment with a specialized first episode service as well. So I'll be really curious as to how different teams across the state and across the nation are providing case management supports. And I think also thinking about the importance of in community or at-home visits and how we can expand our capability to do so, if not with therapists because of certain regulations, then with maybe, treatment extenders, like family partners, family and peer support as well. Third, I think we talked about this, talked about how periodic treatment reviews can really create opportunities to revisit goals, preferences, and progress, all of which reinforces engagement. So our MGH team, for example, always had an annual treatment review to cover all of this, but we were really inspired by Erin's team as well with the brief, check-ins 1 month, 2 month out from initial intake to see how they're feeling about treatment, what other services they're not engaged in yet. And so we just started implementing this yesterday. And finally, and I think this speaks to Leslie's question just now, can we maximize recovery if we framed and normalized first episode CSC services as a family inclusive or family-based treatment right from the outset? I think the teams are already finding that the messaging of family services, the timing of introducing family services is really important. And I think, we also need to have a lot of flexibility around how families can participate in treatment. So I think to Leslie's point just now, a lot of times consent for family involvement, whether that's signing releases of information for treatment team to share information with the family members, is a very black and white decision. Family providers are asking, do you want your family to know about your treatment progress? Yes or no? Do you want your family do you want our team to be in touch with your family? Yes or no? And if they say no, the only time we can break confidentiality is when there's like a clear safety risk or emergency. But by then it's really too late to get family support to prevent, those crises from happening. So, I think revisiting those decisions are going to be really crucial, like Leslie's team is doing. But, how about asking, like having a much more patient-centered discussion, and perhaps, whether a family partner is doing this or the family clinician is doing this in their first visit or even during the first kind of treatment orientation, where there is a longer discussion around who would you like to be involved in your care. And this may not be a family member. This is any trusted person in their support system, and really brainstorming with the patient in terms of who their support system is. It could be a trusted adult in the community. It could be a roommate. It could be a friend. It could be a partner. So first asking, who is family to you? And then how would you want them? Rather than do you want them, is how would you want them to be involved in your care? In what aspects? Is it, to only notify during crisis situations? And what counts as a crisis? Would you like them to be part of your decision-making around medications, around how to help you remember when to take your medications? In what scenarios, can family really support you? And in what scenarios can we reach out to your family if you don't want them to be involved in such a regular basis? What if you missed several appointments or haven't picked up your medication? You know, your family can really support you in staying well. Can we inform them in these cases? So really working with the patients to open up this discussion on their flexibility around family involvement in their care, and, you know, really enhancing or reinforcing that with like why that could be important to you, to understand, you know, what is their areas of resistance as well and how we can problem solve around that. So this really, I think, you know, a more open, a longer discussion around this really respects to patients' autonomy, while also giving many opportunities to convey how families can be supportive in different scenarios, especially around preventing a relapse or crisis. Another strategy that came up that I thought was, you know, really important to highlight, but only one or two teams talked about it, so it didn't present as significant, but I really wanted to share this. Some teams, I think maybe one or two teams within Massachusetts, practice what I call as a no wrong door policy for family contact, meaning that, you know, so this is in contrast to teams that had only like one line of communication with the treatment team through the designated family clinician. Meaning, so, you know, teams can only convey, so families were only directly communicating with the family clinician and not with the rest of the team. And then there are teams where families are going to different team members for different needs. If there's a problem with medication adherence and side effects, you know, they're reaching out to the psychiatrist. And then when there is, you know, distress that they're observing at home, that they think the patient that their loved one isn't talking about with their individual therapist, they're sharing that information with the individual therapist. And then, you know, families are knocking on the door of the supported employment specialist because they want the SEE specialist to help with finding an internship opportunity this summer. And then, you know, there are teams who really welcomed family contact to any provider. And then they'll coordinate with this information, you know, with the rest of the team. And I think this kind of approach really ensures that any team member can actually respond to the family's needs and also use that as a way to provide, you know, tidbit sizes of education for whatever components of care that the families were asking about, instead of entirely relying on the family clinician to provide that. I'm curious if, you know, some kind of maybe anticipated challenges that some of you all might think this might come up in your teams if you all were to employ these kinds of strategies. Because what we found in a secondary study as part of this study, we also looked at provider attitudes towards family involvement. And we found that different provider roles in the team also had different levels of positive attitudes towards family involvement. So, you know, if we were to take this approach of CSC as a family inclusive treatment, and the whole team is engaged in some form of family involvement and education, then I think it also requires that the whole team, all the providers and all the roles, not just clinicians doing family intervention or not just family partners, that should be trained in basic family engagement principles and family education for psychosis. In terms of some caveats and future directions, you know, I think as I mentioned, I think client level factors still play an important role here. One thing that I'll be really interested in studying in the future is thinking about, you know, what are some of the differentiated strategies that teams can take for different high-risk profiles. So, patients who are medication non-adherent or refusing medication, patients who have persistent substance use, patients who have very little family support. What can teams do for these different profiles of patients? And I think having culturally adapted approaches for diverse populations is also very vital. We know that consistently Black families and patients have higher disengagement rates and are disengaging at a faster rate than their white counterparts. So what kinds of specific strategies or even representation and training within the team needs to happen to help engage with these diverse populations? I think as we were interviewing and learning from these teams also, it started bubbling up how we needed different engagement strategies for different CSC components. Peer support and supported employment tend to be lesser utilized in some first episode teams. So how do we promote these services or get people engaged in the services to really maximize their full recovery potential during that first episode period? And I think where we're going with these findings is thinking of like, okay, what could be some best practices and a package of engagement strategies that we can test with future implementation trials to see if, when teams do these certain strategies, whether their patient retention and family engagement improves. So I've done a lot of talking already, so I'd love to hear from you all. Open to any questions, feedback, thoughts, but also, would love to just open it up to a really lively discussion where you all can share whether these findings track with your clinical experience, whether there are other strategies that have been successful in your team, and whether you might try applying some of the strategies that we talked about, and whether there could what might be some challenges there. So thank you so much for your attention.
Yeah, thank you so much, Cheryl. Happy to open up to questions. I have one partially a question and partially a resource. I know we have a couple of family partners on the call right now. I wonder and that's unfortunately not something that is too common across Massachusetts programs, but it's kind of a growing space and role. So one thing I wanted to share is just that the Department of Mental Health in Massachusetts recently published some practice guidelines for a family partner role. So kind of guidelines and also training videos for that. But was that something that you guys looked at? Did you talk to programs that had family partners?
This is a great resource. Thank you for sharing that, Kelsey. We did talk to programs that had family partners. And at the same time, I think that maybe I can't remember, maybe there were 2 programs that had family partners with their own lived experience for caring for someone with psychosis at the time that we did the interview. But I think since then, 2 more programs have included family partners as part of the CSC role. So, I think the inclusion of family partners is definitely a growing area of interest and need that programs are starting to see the value of. So it's nice to maybe for our study to kind of show their value. But I'm so interested to hear the work that other family partners are doing in their programs as well. I think the difficulty with the family partner role, and I think with peer specialists or even community health partners roles as well, is that they can be very diverse. They take on so many hats, right? And you know, what kinds of trainings, what kinds of supports are needed to support them in their role is definitely a growing area of investigation. Yeah. Susan.
I told you guys I was going to have something more to say. So I am a certified parent peer, and the psychoeducation material that we use is from Navigate, which may be very familiar to you. And the very first lesson is on collaboration with mental health professionals. And this really, really, really resonates for me. While I do not have experience with a child with psychosis, I have over 35 years of experience with my son with his mental illness. And this may be a generational issue, not sure, but I certainly know that I encountered a lot of top-down thinking and treatment over those years. And that absolutely is something that I think has to go away. You know, in this program for sure. And I emphasize that. Instead of talking about collaboration, which is kind of a fancy word, I say teamwork. And I said, and the thing is, not only are you getting support from a team, I said, let me tell you something. You, parent, mom, dad, are on the team. You are part of the team. And guess what? Your loved one is on the team. We are in this together. And I think if we can promote more of that thinking to understand that we all have a stake in it, it's going to be so much better. And what we're talking about is empowerment and agency, which is win-win.
You know, I could not have said it better. And I think, you know, like what Melissa put in the chat as well, family partners with lived experience are really critical. And I think that really is where, you know, the peer movement, the peer recovery movement is really doing this with advocating that there's nothing about us without us, right? So, and I think, you know, family involvement in our first episode, care, in supporting their loved ones' care with the family partner support, with family voices in the room as well, is really critical.
I wanted to point out too, Kim had some great comments in the chat. Kim, are you available or anything more you want to say about that?
Oh my, I'm so grateful Kim fielded all these great questions for me. I think Kim might have had to hop off, it looks like, early. Mhm.
Great. Well, recommend folks looking at that, but really around the recommendation of involving families, kind of what we've been saying is a core part of the treatment team, not just as a like extra option of the service, but yeah, that like the C of coordinated specialty care, that coordination is not just kind of within the team, but within the whole support system.
Thank you, Jude, also for your comment around how family partners is not just the person who has lived experience supporting their child. It can also be siblings. It can also be a partner. Great point.
Hi, Cheryl. Julie McCarthy from McLean. Wonderful presentation. And I had a quick question actually about the sibling piece. Certainly in the family research that I've done, a lot of the folks that we work with are parents, and I know that's the primary family role that we often see in first episode psychosis clinics. But what data, if any, were you able to collect about the type of family member that folks were working with, in terms of how much engagement there was with siblings, versus parents, or with mothers versus fathers, or other types of, people identifying as family members?
Great question, Julian. That's not that I wished I spoke to you earlier. We did not collect that data in terms of which family member or which support system or care partner was involved in family engagement. What we know from the literature, and typically it's mothers who are involved in family interventions. And I think there is a lot of stigma still around sibling involvement, even though there is, a lot of important opportunities for talking about prevention as well, and supporting the mental health of siblings. But we just anecdotally, and I think just from clinical experience, we see a lot of families either wanting to protect their sibling who does not have psychosis from the mental health system, or not wanting them to be overburdened with also caregiving for their sibling who has psychosis. And then we also have siblings who don't want to be involved, perhaps for stigma related reasons as well.
Thank you so much.
Thank you, Julie. Monica?
So I was having a conversation earlier this week with someone who is a very strong leader in the peer community, and I was talking about the importance of involving family. And he mentioned to me, what about, some families are toxic, and that's a real thing. And certainly, I mean, as a parent, I see two things. One is that sometimes the person with lived experience has, particularly with psychosis, narratives around their parents that aren't true. I can say that that's happened to me with my son, so I know that's true. So a peer listening to my son might think I was a toxic parent, for example. So I think there's some complexity here that we can't just write off. But on the other hand, there are toxic families bona fidely. And how do you see CSC programs sort of figuring that out? And then in that case, we were talking about alternative sort of family of choice. I think Kim put something in the chat about when someone asked, how do you define family? Then helping that individual end up with their lifelong team, because I would say families forever. And that's actually when this guy said to me, except if they're toxic, right? So you want that forever family for people when they're leaving a CSC program or whatever, like for the rest of their life journey. And like, I'm rambling a little bit, but I think this is a gnarly question that's worth talking about, is when is family not the right support system? And then what do you do? How do you evaluate that? And then what do you do about that?
Yeah, I like you put it, this is really complex. I think, really starting off first with getting the client's preference and choice around, their family of choice, right? So not to have any assumptions of who that support system is. And I think we don't ask that question early on enough, right? About who their family of choice is, who can be care partners in your recovery journey. And I think, maybe family kind of steps on several kind of like landmines sometimes, but really it's it's care partners. Who do you want to be a care partner in your recovery journey as well? And leaving that and revisiting that with the client's preference and choice up front, I think is going to be really vital. In terms of assessing when family is not the right support, Susan, it seems like that I would love to hear your thoughts and anyone's thoughts around that as well. You know, obviously, anything that is explicitly around abuse, violence, we would refrain from that person's involvement. But I think, you know, because this is also like transitional age youth where there is this, I guess, dilemma or this like stage of growth towards independence, I think supporting through individual therapy and even with family work as well, elevating the client's voice and choices and autonomy around their own independence, what they need for the independence, how much support they want. It's going to be that delicate dance. Yeah, but also an important, I think, development and treatment goal to keep in mind. Yeah.
Yeah, and I'll be honest, since you mentioned me, I'll just go ahead and say something. But I probably am more forward leaning in my thoughts with parents than I'm supposed to be, according to all my training. But oops, that's where I am. And I know that when I encounter a parent that is adamantly against medication, I'm just trying to figure out all the different ways I can try and be persuasive that it's really a positive thing and it's important, it's foundational, all that kind of stuff. But also when the parent just has unrealistic expectations about recovery, because I think, and I kind of wanted to say something about this, I don't think that we do a really good job of explaining mental illness to sometimes. And I know I'm very involved in NAMI, so I know this word is not used. We don't talk about it being chronic, but it is. And we need to use that language because you cannot take an aspirin and the headache goes away. Yeah, the headache goes away, but you can't take an aspirin and boom, psychosis goes away. It is something that you must learn to live with. It is a process, it is a journey. And we need to just talk more to the clients and to anyone who's involved along those lines. It's education.
I completely agree. You know, this is education and an important education to put up front about the trajectory of this illness, the chronic kind of episodic nature of this illness. And I think another really good point that you brought up, yeah, I'm blanking right now, but I'm sure it'll come back to me. Thank you. Great discussion.
Yeah, Leslie.
So I guess, in reference to that kind of, what if the family is toxic? I think it's really important that we might have that personal opinion, but that is still that person's or participant's family. And they may have a very different opinion about that and the dynamics. And so I think it's really important to just meet the family where they're at. I've had some, and it's really rare, but I've had, situations where the family member is like, I'm not the problem, they're the problem. And they didn't really engage in family at that point then. But, the families that I can engage with, I'm meeting them where they're at, and they're going to benefit from any kind of skills we can provide them in communication. If you have poor communication skills, you can exacerbate any situation. If you're able to instill or pass along some communication skills that help that family member in difficult situations or difficult conversations. It's only going to benefit the family and the participant in the program. So I think it's just really important that we keep our own opinions outside of it and our own judgments and meet the family where they're at.
And some great comments too in the chat. Thanks, Melissa and Corey, around it's a very different situation, right? If they're kind of toxic and still living in the same household or having a lot of contact versus more of a like no contact or removed relationship with that person. Yeah.
I think you raise a really interesting point, and some of my emotional involvement in the topic is showing, but because I know that my son might possibly describe me as toxic. We're estranged, so I'm not bothering him at this point. But and I object to that label, but I think, Leslie, you're right. It's his perception that matters. What reality may or may not be. If he doesn't want me in his care team, that's all that matters. And so the need for in my original question, the idea that you needed to evaluate, was the toxicness accurate or not, I just heard Leslie say that's kind of irrelevant, right? It's what the person wants. So thank you for that. I really appreciate that.
And also acknowledging, Sarah, your comment in the chat too around it being helpful for there to be like a separate space for family education and support, and thinking about how that like stress in the households kind of is improving or supporting kind of overall well-being and yeah, kind of recovery.
Yeah, it's fresh on them, and it's why I'm sorry that I missed the first part, because I was actually meeting with a family, but it was an interesting thing, because the son really needs our services, and the mom, they're from another culture, and she's very wary, and I learned something in meeting with them that I could never have predicted what her concerns were, like about diabetes and her own diabetes. And she's very focused on her son's blood sugar. And I was like, if I hadn't met with them, I mean, they were basically like saying, I mean, they want to stay with parts of the program, and we're still going to meet again. But it was like, I heard her say, like, he was so smart in high school, and he needs to get his confidence back. And, there was this interpretation on our team that she was kind of blocking his care. And I heard about it, and I just was like very empathetic of her concerns, and the psychiatrist ordered blood work, and, we're like, so I just think that sometimes we can, especially where there's cultural barriers, we really have to listen well, and just be curious.
Really beautiful reminder. Thank you, Sarah.
Something else that we can get tripped up on, and I'm sure you guys have encountered this, and that's religious considerations. Because, I'm a very serious church person, but I don't believe in praying the devil out. But certainly some of our parents do believe that. And I really had to be very, very cautious in that area of discussion. I don't know the answer. I just know it's a challenge.
Right, and kind of cultural and religious concerns or kind of influences on how families are engaged. That is maybe it could be a whole nother hour and a half long discussion. But yeah, Cheryl, was there anything kind of related to that came up in the interviews?
I think a lot of the perceptions that you all are talking about that, providers do hold in the team, and I think the provider attitudes towards family intervention scale that we developed through literature review, like tried to kind of assess that quantitatively, that, you know, providers do think that some families that families are hard to engage with for several of these problems, right? Whether it's religious and cultural differences and a lot of stigma around mental health that could be culturally influenced, and also around the fact that stereotypically the families of people with psychosis are high expressed emotion and have high conflict, or that, you know, there are like toxic families, or patients don't want their families to be involved. So I think a lot of these attitudes that providers have about families and working with families, we realize we're actually correlated with poorer fidelity to family engagement. That we, you know, with this study found that was related to lower family engagement rates as well. But I think, you know, to what Sarah's bringing up, what Leslie, Susan, Monica's bringing up, I think that there's just a missed opportunity with training, or maybe we still have to develop better training for all the teams around working with families and the nuances with working with different types of families, and how to really listen, like Sarah said, like listen with curiosity and listen with empathy to these families as well, rather than ruling out that, you know, families are hard to work with. And that these, and I think that, yeah, we're not maybe doing, and I think that with better training, with actual practicing of this nuanced family work, like what Sarah put in the chat, you know, family involvement that's can be offered with boundaries, but still in a patient-oriented, recovery-oriented way, and how to do that. If providers start realizing that that is possible, and we train them in how that is possible, I think that I'm more of a behaviorist, so I think attitude can change that way with good practice. Yes.
I have my 2 cents on that is I think people are very afraid, and they are like, I'm not a family therapist. And that, like, I think there's a lot of fear around it, and around like not having the right training, or I don't know. And I think I appreciate you saying that it's a training issue, because I think that we can do better at you know, at training with, you know, especially those initial in the initial engagement.
Yeah. Thank you, Sarah. You are definitely one of my trainers, so I owe a lot to you. Thank you.
Great. Well, I know we're just getting to the end of our hour here. Any last questions or comments that folks want to throw out there? If not, thank you so much, everybody, for being here. Thank you, Cheryl, for first all the work that you've done on this project, and also for sharing it in such a nice way. Also, very much appreciate all of the comments in the chat. This has been a really great discussion.
Yes.
Yeah, thanks, everyone. Appreciate you being here.
Yes, learned so much from all of you. Thank you so much. And I'm just going to drop my email in the chat.
Oh, yeah.
Please feel free to reach out or say hi, so that I can at least have your email address as well. Would love to carry on this conversation and learn all that you do with your teams. Thank you. It's
Yeah.
at mgh.harvard.edu.
Thanks. Have a great long weekend, everyone.
Thank you. Take care.